Hi, I am Dr. Saqib, and today I will discuss with you the extraocular muscles anatomy. So they are 7 in number. First, you will see the 4 recti: the superior rectus, the inferior rectus, the lateral rectus, and the medial rectus. These 4 recti, and then the superior oblique and the inferior oblique. These are the 6 muscles here, and one is the levator palpebrae superioris. So these are the 7 in total. So muscle of each eye work together in a coordinated manner to fix both eyes onto an object. So coming back, here you see this is the eyeball structure, and here you see this is the sclera showing the muscles with the insertion. We'll talk to you in detail, and this is the pupil, right? So this is the thing. This thing is already discussed the anatomy of the iris. So going on, and so we'll talk about these muscles one by one. First of all, levator palpebrae superioris. It originates from the lesser wing of the sphenoid above and anterior to the optic canal, and inserted into the dorsal plate and skin of the upper eyelid. It has two lamellae of insertion. One is into the dorsal plate and the other one is into the skin of the upper eyelid. One of those is the Muller's muscle. I'll tell you immediately right from some time. And here is, this is one lamella. This is a levator palpebrae superioris, right? So it is nerve supplies oculomotor nerve into the one part and the sympathetic nerve fibers to the other part. Its action is the elevation of the upper eyelid. So some smooth muscle fibers are also present. I told you this is the second part of the levator palpebrae superioris, and I told you this innervated by the sympathetics from the superior cervical ganglion. So this part is called as a Muller's muscle. So this is the reason why there is a mild ptosis in Horner syndrome when the sympathetic fibers to the Muller's muscle are compromised. Ptosis is the drooping of the upper eyelid. Here is the picture enlarged, and here you see this structure is the, this round structure is a tendinous ring, the common tendinous ring, and I will tell you its importance and the structures passing through that and the structures attached to that. So first of all, we'll talk about the 4 recti. The recti, superior, inferior, medial, lateral, originate from tendinous ring around optic nerve and medial part of superior orbital fissure. And here you see this picture, right? This is the origin of the recti. This is the, optic nerve, the medial part of the superior orbital fissure over here. I show you a large picture over here from this one. Yes, here you see this is the tendinous ring, and these are the all recti, right? 4 recti, I told you already. And this is inside the common tendinous ring. This is the optic nerve, and this is the medial part of the superior orbital fissure. This is labeled. And these are 4 recti are inserted into sclera anterior to equator of eyeball. Yes, this is the insertion of 1, 2, 3, 4. Inserted into sclera. This whole structure is the sclera, white of the eyeball, and anterior to the equator of the eyeball, they are inserted, these recti muscles. So I will talk now about superior oblique muscle. It originates just above tendinous ring, right? Here you see, this is the superior oblique muscle. Here, this is the muscle, and this here is originating. Let me enlarge. Here you see, this is a superior oblique. Here you see this. So just above the tendinous ring, it originates and inserts via tendon, which loops around a fibrous pulley on the medial part of the roof of the orbit into the sclera, just lateral to the insertion of the superior rectus behind the equator of the eyeball. So this is the pulley. So let me enlarge the picture again, zooming in. So you see, this is the tendon of the superior oblique, and this is the pulley, fibrous pulley of the trochlea. And from here, it goes back this, to superior rectus and inserted into here. This is anterior to the equator of the eyeball and between this superior rectus and the lateral rectus. Yes, this is the insertion. And now a few words about the inferior oblique. It originates from the medial part of the floor of the front of the orbit. Here you see this. This is the medial part of the floor of the front of the orbit, and it goes from here on, passing on under surface of the eye. You see the laser, and it is inserted also here between the lateral rectus and the superior rectus. Now, let me enlarge this as well for you. Here it is. Yes, here you see. Yes, it is coming from here, this part of the orbit inferiorly, going on the undersurface of the eyeball and inserted over here between the lateral rectus and the superior rectus. So now I will talk to you about the extraocular muscles nerve supply. That is a simple formula. That is a sort of universal chemical formula. LR6, SO4, all others 3. So what is this? Lateral rectus supplied by 6th cranial nerve, which is abducens. And SO4, what is this? Superior oblique supplied by the 4th cranial nerve, which is the trochlear. And all others are supplied by the oculomotor's 3rd cranial nerve, right? This is the thing. So this is a nerve supply formula, and I've already explained to you the nerve supply of the Levator palpebrae superioris. So very interesting, the movements of the eyeball, very intriguing and very interesting. And I've tried my best to explain it to you in a very simple manner. And I believe I am successful. You will tell me in my comments down below. So there are rotations, movements occur as rotations around following 3 axes. First is this vertical axis. The second is the transverse axis. This is the transverse axis. And the third is this anteroposterior axis. So the 3 axes. And the reference point, very important that we have to take a reference point for the description in direction of the movement of the pupil, right? So one reference point is this pupil, movement of the pupil, right? So when the position is neutral, and this is the upper pole of the eyeball. Just two points, you can take any one of those for the reference point of the movement of the eyeball, extraocular muscles being in action. So as the eyeball rotates around vertical axis, this is the vertical axis. So when the movement is occurring around this axis, what happens? Pupil is moved medially. It is moved about medially towards this direction, right? This direction. So that will bring about adduction. And if it is moved laterally, that will bring about abduction. You follow the laser, right? So as the eyeball rotates around transverse axis, this is the transverse axis. So this movement will bring about the elevation. The pupil will move upwards. It will bring elevation, or the downwards. This pupil will move downwards. That will be bringing about depression. So if the eyeball moves in the anteroposterior axis, this is the anteroposterior axis, and the superior pole of the eyeball moves medially, right? This pole, right? This moves medially here like this. So it will be called as medial rotation. Medial rotation is also known as this intorsion. Medial rotation or intorsion. Or it will be moving to this superior pole of the eyeball laterally. It will be known as the extorsion. Lateral rotation is called as extorsion. Rotational movements accommodate changes in the head position. So a word about nerve lesions here. They lead to loss of these movements and result in diplopia. It's a generalization I will tell you briefly about nerve lesions in the end. Movements also occur around the 3 axes at the same time. Hence the need of 3 terms to describe the direction of movement from primary position. So actions, now they are summed up again over here. to make the things simple and understandable. Elevation, depression, adduction, abduction, and rotation, medial and lateral. Medial rotation is, I told you, intorsion, and the lateral rotation is extorsion. So these are the movements brought about the extraocular muscles. So now I will focus on the medial recti, right? The medial recti, as this is medial, it will do the adduction. Medial recti cause adduction. So they move eyeball in one axis only. Told you already, one axis of medial rotation. What is that? And the lateral recti, right? They will cause abduction. See, right? They also move the eyeball in one axis only. Superior rectus, I will talk about this superior rectus. It brings elevation like this. It's superior rectus, bring about elevation, then adduction over here, right? And then the medial rotation, the intorsion. So this is the movements, right? Superior rectus brings elevation, adduction, and medial rotation. And then about the inferior rectus, this direction of pull, it brings about depression of the, you can say pupil or the eyeball, this pole. Superior pole brings down, it brings down it below towards the inferior direction, and adduction brings it here, and the lateral rotation, this is extorsion, lateral rotation, it is rotated like this, like this, like this. So superior oblique, this is very interesting again, superior oblique, though it is superior, but it is superior oblique, right? The movement is depression. Muscle is superior oblique, but it brings about depression. And also the abduction, the lateral side, the abduction, right? And the medial rotation, which is the intorsion, right? It will pull it, the eyeball like this. So it will bring about the medial rotation. So talking about the inferior oblique, as though it is inferior oblique, but it will bring about elevation and also the abduction and the lateral rotation known as the extorsion. So pure elevation, how it is brought about? Pure elevation, movement of the eyeball upwards, pure elevation is brought about by these two muscles, inferior oblique and the superior rectus. They will act together. And the pure depression is brought about by these two muscles, superior oblique and the inferior rectus. So a tip to remember these complex vectors of movements is that cranial nerve fourth, the trochlear nerve, which was formerly known as the pathetic nerve, it makes you look down and out. This is its normal function of the cranial nerve fourth. And you remember down and out, this I will tell you in the nerve lineage, and I will relate, and that will be very interesting. To direct the gaze, coordination of both eyes must be accomplished by the paired action of the contralateral yoke muscles. Functionally paired contralateral extraocular muscles, they are the yoke muscles. For example, what are the yoke muscles? I give you example. In directing the gaze to the right lateral rectus and the left medial rectus, they are the yoke muscle, right? So check ligaments, medial check ligament and the lateral check ligaments, they are formed by the expansion of their facial sheath of these respective muscles, the medial rectus, the lateral rectus, and they limit abduction and the adduction respectively. A blending of the check ligaments with the fascia of the inferior rectus and inferior oblique muscles form a hammock-like sling, the suspensory ligament of the eyeball. A similar inferior check ligament from the facial sheath of the inferior rectus retracts the inferior eyelid when the gaze is directed downwards. Collectively, check ligaments act with the oblique muscles and the retrobulbar fat to resist the posterior pull on the eyeball produced by the rectus muscles. So in diseases or starvation that reduce the retrobulbar fat, the eyeball is retracted into orbit. This condition is called clinically as an ophthalmos. So let's talk about common tendinous ring. This is also known as Annulus of Zinn. Here, this it is. This, you see the laser. A fibrous ring that surrounds the optic canal and the medial part of the superior orbital fissure. I already told you. It is the site of origin of the four recti muscles of the orbit. 1, 2, 3, 4 recti. What are the structures passing through common tendinous ring? So nothing to worry, just see the picture and you can spot out. First of all, this is the optic nerve along with this ophthalmic artery. This is the one thing passing through this ring, and then oculomotor nerve, third cranial nerve, superior division, and the oculomotor nerve, third nerve, inferior division. These two, and then this abducent nerve, cranial nerve, sixth, and the nasociliary nerve. These pass through that. So in the last, a very important this age test. You see this age test. You see, you follow this age pattern. The test, all the muscles, extraocular muscles, are tested with a single test, age test, which is you can use a tip of a pen or a finger. You place it between the two eyes. The head of the patient is stationary. It will not move the head. So, right, you can use the tip of a pen here, right, in front of the eyes, and you follow that age, right, this, and the patient, first of all, you will go like over here, first over here, you bring the tip of the pen over here from this side, but this will test one. This would be the right eye lateral rectus. This is the right eye, lateral rectus is tested, and simultaneously from the left eye, this is the medial rectus is tested. Also with the nerve play, you can check. This is the fourth cranial nerve, the lateral rectus, and the third nerve for the medial rectus. This is LR4, right? So these two muscles, I already told you, lateral rectus and the medial rectus, they are the yoke muscles because they simultaneously bring about this movement, which is the, what is that? For that, this is the human abduction, right? Then in the second phase, like this is H completion. Second phase, number 2, what it will be testing, superior rectus of the right eye and the inferior oblique of the left eye. Both side, this third cranial nerve is tested. And in the third phase, this third, bringing the tip of the pen downwards, and right side inferior rectus and the left eye superior oblique would be tested. SO4. This is the fourth cranial nerve. Then you go up and bring your, in the fourth phase, bring the tip of the pen over here, from here to here. And from here to here, what is tested? Again, you see, this is the medial rectus of the right eye and the lateral rectus of the left eye, right? So these are again the yoke muscles. So then you bring it down, tip of the pen from here to here, and what is now tested? Superior oblique of the right eye and inferior rectus of the left eye. And in the last phase, completion of the H, you go upwards over here, from here to here, flow to upwards, and the right eye inferior oblique is tested, and the left eye superior rectus is tested. Right eye inferior oblique and left eye superior rectus is tested. So this is the H. From here you can see this, and this is a very amazing H test. All the extraocular muscle, all the 3 nerves, which are the third, fourth, and sixth, are tested. They are numbered over here. I mentioned it too. So a very brief words about the nerve palsies. This is cranial nerve 3. I told you already, ptosis, mydriasis, and eye position is down and out. So this is very interesting. What was the eye position down and out, which was the normal function of a nerve? That was formerly known as a pathetic nerve. That was a cranial nerve 4th. Its normal function is to bring the eyeball down and out. And then when there is a palsy, the paralysis of the cranial nerve 3, that makes the eyeball down and out. So that is the thing. If the cranial nerve 4th is paralysis, vertical or torsional diplopia will occur. And in the last, if there is paralysis of the cranial nerve 6, right, it will be causing inability to abduct eye, right? If you remember the formula, so that was LR6, lateral rectus is paralyzed. So that is the inability to abduct eye. So thank you very much for listening, and I request you to encourage me. please subscribe my channel and comment down below.